It is an operative procedure whereby the fetuses after the end of the 28th week are delivered through an incision on the abdominal and the uterine walls. Factors for raising the Cesarean section rate. Raising the incidence of the primary Cesarean delivery. Identification of risk fetuses before the term. Identification of high-risk pregnancy. Wider use of the repeat CS. Rising rates of the induction of labor and the failure of the induction. Decline in the operative vaginal delivery and the vaginal breech delivery. Increased number of the women with the age greater than 30 years. Wider use of the electronic fetal monitoring and increased diagnosis of the fetal distress. Fear of litigation. Indications. Absolute indication is a vaginal delivery is not possible. Central placenta previa, contracted pelvis, cephalopelvic disproportion, pelvic mass, advanced carcinoma cervix, vaginal obstruction. Relative indication. Previous Cesarean delivery, fetal distress, dystocia, antepartum hemorrhage, placenta previa, abruptio placenta, malpresentation, failed surgical induction, recurrent fetal loss, hypertensive disorder, medical gynecological disorder, diabetes, coaction of aorta, MS, AR, AS, Marfan syndrome, mechanical obstruction. Types of operation: lower segment CS, upper segment classical CS, modified classical CS. Lower segment Cesarean section. Patient preparation, counseling, written informed consent, preoperative evaluation, preparation of the incision area, bladder catheterization, blood arrangements, antibiotics, heparin therapy. Patient preparation in the operation theatre. Left lateral tilt at least 15 degree. Oxygen inhalation, pediatrician should be available. Auscultation of the fetal hearts before starting. Anesthesia: general anesthesia, spinal anesthesia, epidural anesthesia, local infiltration. Skin incision, prefenestrational incision, gel consent incision, midline incision, paramedian incision. Uterine incision, peritoneal incision, transverse cut across the lower segment with the convexity downwards. Muscle incision, low transverse slightly below the peritoneal incision. Ease of operation, less bladder dissection, less blood loss, easy to repair, complete reperitoneization, less adhesion, less risk of the scar rupture. Lower vertical, classical incision, J incision and the inverted T incision. Two index fingers are then inserted through the small incision down to the membrane and the muscles of the lower segment are split transversely. Delivery of the head. Members are ruptured, suction of the blood mixed amniotic fluid. Hooking the head with the fingers by the elevation and the flexion using the palm. If the head is jammed, push up the head by fingers introduced into the vagina. Wrigless or the bottom forceps also be used. Mucus from the mouth, pharynx and nostrils is sucked. Delivery of the trunk. After the delivery of a shoulders, IV oxytocin 20 units or methadone 0.2 mg is to be administered. Head tilted down for the gravitational drainage. Cord is cut between the two clamps. The Doyen's retractor is reintroduced. The optimum interval between the uterine incision and the delivery should be less than 90 seconds. Removal of the placenta and membrane. Traction on the cord with the simultaneous pushing of the uterus towards the umbilicus per abdomen using the left hand. Suture of the uterine wound. Alice tissue forceps of the green armitage. Hemostatic clamps are used to pick the margins of the wound. The uterine incision is sutured in the 3 layers. First layer suture material is no zero chromic catgut or the vicryl. Continuous running suture taking the deeper muscles excluding or including the decidua. Second layer continuous suture placed taking the superficial muscles and the adjacent fascia overlapping the first layer of the suture. Uterine muscles may be closed taking the full thickness muscle and the decidua. The peritoneal flaps may be opposed by the continuous inverting suture. Concluding part. The moths placed inside or removed and the number verified. Peritoneal toileting is done and the blood clots are removed meticulously. After being satisfied that the uterus is well contracted, the abdomen is closed in layers. Classical Cesarean section. Abdominal incision is always longitudinal 12.5 cm starting from below the fundus. Delivery common as a breech extraction. The uterus is eventrated. The placenta is extracted by the traction on the cord or removed manually. Complication. Maternal. Intraoperative. Extension of the uterine incision, uterine laceration, bladder injury, urethral injury, gastrointestinal tract injury, hemorrhage, morbid adherent placenta, placenta accreta. Post-operative complication. Immediate. Postpartum hemorrhage, shock, anesthetic hearts, Mendelssohn syndrome, infection, intestinal obstruction, deep vein thrombosis, and the thromboembolic disorder. Good complications like the Sanchinias or the Frank-Pass, hematoma, dehiscence, burst abdomen, necrotizing fasciitis, secondary postpartum hemorrhage. For the gynecological, the menstrual excess or the irregularities, chronic pelvic pain or the backache, general surgical, incisional hernia, intestinal obstruction due to the adhesions and bands, future pregnancy, there is a risk of scare rupture. Fetal, iatrogenic prematurity, RDS, and the maternal and the perinatal mortality.